એવું થોડી હોય એટલે ડેમેજ થઈ ગયું હોય પાછું. ગુડ આફ્ટરનૂન સર.
Good afternoon, Urvesh.
કેમ છો સર, મજામાં?
Yes, all good, all good.
ઓકે,
શું ચાલે? અવાજ clear છે?
એકદમ ક્લિયર સર.
And can you see the slide as well?
યસ યસ સર, આઈ કેન સી
All right, all right,
વેરી વેલ.
all right. PC bhai,
Hello.
Tushar,
Yes.
all clear? તને host ના rights આપી દીધા છે.
Okay, done. Chal.
Right.
Yes, I'll start admitting people.
Yes, even you shall be allowed to admit.
Yes, I'm doing that.
આપણે ત્રણ જ હોય તો આપણે ઇન્ડિવિજ્યુઅલ કરી નાખીશું.
Nah, I public.
ઘરનો
People
છે.
are getting in.
ના, ઉર્વેશ તો
People are getting in. Don't worry.
Is my camera on or is it off?
Your camera is off.
Is off, ne?
સર
Yes.
યસ સર, when you are presenting, your camera will not work.
Okay. Well, Tushar, you let me know when we start. See, bye.
Yes, I'll let you know when to start. Once we reach to 15 participants, we will start on. Good evening, students.
Good evening, student.
Today we are having our fourth lecture of the masterclass e-series. Today's presenter is Dr. Adarsh Desai. He is going to present the presentation on the maxillary sinus, a maxillofacial surgeon's perspective. Meanwhile, in between during the lecture, whenever you have any doubts, please note it down into the chat box. The answers will be given as and when the sir is free. Others, I think you can start with the presentation.
Good afternoon, everybody. I would request everybody to just mute their microphones and off their cameras. Now, today, in mid of COVID-19, it's a very good initiative taken by the AOMSI Gujarat to present ongoing lectures for the postgraduate students. Today, we're going to talk about maxillary sinus, a maxillofacial surgeon's perspective. I hope the voice and the slides are clear to everybody. Tushar?
Yes.
Right. So maxillary sinus, as a postgraduate, was a very small topic which could be counted as a minor surgical procedure and was given a very less emphasis while studying for it. Now, when I was preparing this lecture, and in between COVID-19, I had a very less resources for preparing this lecture. Thanks to Rushit, got a few PDFs and searching the net. There's so much resources available that on maxillary sinus and its advances, so much research going on that I guess somebody can do a post-graduation in maxillary sinus. That much of resources are available online. So I'm looking at the perspectives and the research available. It's very difficult to put it in 1 hour, half an hour in a lecture. So what we'll do in the next 1 hour is I'll try to give you a few glimpse of what is maxillary sinus, how do we approach it, how do we diagnose, how do we treat it. So in the next 1 hour, we'll be using a lot of visuals, lot of x-rays, lot of imagination, because I always feel online lectures are a little boring because of one side, one person keeps on speaking continuously. So we'll look into a little imagination so that your understanding of your basics becomes more clear. So to start off with maxillary sinus, what is a maxillary sinus? I would say it's also known as an antrum of Highmore, and it is nothing but a paranasal sinus situated in the body of maxilla. Right? It's bilaterally placed in the front of the maxillary bone. Now, what does it do normally? We require it for humidification of air, the physiological functions of a maxillary sinus. Is it very important? Yes, it is. It is a pneumatized cavity which allows humidification of air, what we inspire, and during expiration. It does harbor cilia inside the cindarian membrane, which traps the dirt, the pollutions, the bacteria, and it filters it out to the respiration lungs. So it makes it more pure air when it goes inside your lungs. Apart from that, it lightens up the skull. The weight of the skull is lightened up by the presence of a maxillary sinus. The voice resonance is added up by the maxillary sinus. So it is an important bony cavity present in the facial structure. And to visualize it, I would say, let's imagine a sinus like a closed vault. Why a closed vault? Because anatomically, this sinus is enclosed by cortical plates all around. On the roof, the floor, the mesial side, the lateral side, anteriorly, posteriorly, it's a closed cavity. The only area which communicates with the external environment is nothing but a small ostium which is present on the lateral wall of the nose. So I would say it as a vault, which is lined by cindarian membrane. That's it. Now when we ask the patient to open the mouth, or when we sit in front of the patient examining it, we cannot assume what's inside. We cannot examine the sinus from outside and say, boss, you have this, boss, you have that. So to look into the sinus, there could be various things. Normally, if we say a normal sinus, what does it have inside? It's just air. And it's good to have just air inside your sinuses. That's it. But apart from air, you can find various pathological conditions. Like one can find infection inside those closed cavities. It can be bacterial, it could be fungi, it could be viral. At present, you can find coronavirus inside as well. You can find an enterolith, a bone pieces after mid-facial trauma, like maxillary trauma, orbital floor fractures. You can have those small pieces running down into the sinus, and a hematoma after mid-facial trauma, a displaced root or a tooth, which could be iatrogenic complication, a dental implant with the advances in dental implantology, and we going in search for that extra bone. We land up into complications, and we can end up pushing those dental implants into the sinus. Bone grafts, again, to get that vertical height, the horizontal height, we tend to put a lot of bone grafts, xenografts, allografts, which can rupture through the sinus and end up into the sinus lining cavity. Various odontogenic cysts, tumors are present in relation to the teeth in the maxillary posterior arches. Local cysts and tumors of the sinus lining inside from the cindarian membrane can also be present, and malignancy. These are a few things which could be present in the sinus when we go and look inside. Now, there are various classifications which have been given. One of the classification which is followed is you can classify maxillary sinus diseases into inflammatory groups. Neoplastic, in that you can go into benign, malignant. Odontogenic. Odontogenic takes up 60% of the etiology of maxillary sinusitis. Odontogenic causes mucocils, granulomatous vascularitis, and silent sinus syndrome. In inflammation, you can have a subdivision of infection and allergic. Infections can be caused by bacterial, viral, and fungal. Allergic, you can have polyps in relation to asthma or any material fungal allergic reactions. Benign tumors, you can see a variation of osteomas to angiofibroma, neurofibromas, malignant squamous cell carcinoma, adenoid cystic carcinomas. You can see fibrosarcomas, osteosarcomas, and odontogenic infections related to teeth, periapical infections spreading into the sinus, periodontal infection, iatrogenic orodental fistula, cystic radicular cyst, dentigerous cyst, odontogenic keratocyst are all reported in relation to the maxillary sinus. Fibroosseous diseases, foreign bodies, teeth, implants, traumatic injuries, foreign objects can be found into the sinus as well. Mucosils, and you may have agnus granulomatosis and a silent sinus syndrome where the etiology is unknown. Well, another classification would be classified as developmental, inflammatory, traumatic diseases, cysts, tumors, and other diseases. In developmental, you can have agenesis, aplasia, hypoplastic, maxillary sinus, supernumerary sinuses. Inflammatory could be sinusitis, mucositis, emphyema, antral polyps, enteroliths. Traumatic could be orodental fistula, communication root pieces, implant, fracture maxilla, odontogenic, non-odontogenic cyst. Tumors could be again benign and malignant. Other diseases could be classified as fibroosseous or granulomatous diseases. So these are the classification which give you a short list of conditions which would affect the maxillary sinus. Now, how do we present when these patients come to us? How do they present to us? They normally present to us with a common complaint of pain, swelling in relation to the maxilla. They complain of continuous and frequent headaches, nose blocks, nasal discharge, nocturnal coughs, frequent epistaxis. If you look into, they may also give you intraoral signs like intraoral swellings, tenderness over the posterior maxillary teeth, discharge from the extraction sockets where there is a history of extraction of before a few days' time. You may have mobility of teeth, unable to puff cheek, cacosmia, leakage of water while taking through the nose, and it could be referred from a dentist. These are the way the patient would land up into our offices at a maxillofacial setup. Now, how do we go about with diagnosing such cases? Now, foremost, when we have such patients with such complaints, it is very foremost to look into a proper protocol of examining this kind of patients. You should start off with a detailed medical and a dental history from how long this patient has been having such signs and symptoms, this complaint. Clinical evaluation into swellings, asymmetry, hematomas, palpation of the surfaces involved. Nasal symptoms, oral symptoms has to be looked into details. We can follow the symptoms, oral examination, extraoral examination, followed by transillumination. You can put a source of light in a dark room setup underneath the orbital ring on the external surface. You can ask the patient to open his mouth and you can see a light illumination on the palate of the same side. If the illumination is positive, that means you have a clear sinus. But when a patient has some opacities or some conditions affecting the sinus fluid levels or any cyst tumors, it can obscure the light passing through the palate and it can give you a negative transillumination. Radiographs, there are various radiographs which could be taken ranging from a small IOPA, occlusal X-rays, PNS. You can take a PA lateral skull. You can take a OMV view. You can take a submental view, USG, CT scans, MRIs, OPGs. Now, since the advent of CT scan, the diagnosis and the usage of CT scan in diagnosis of maxillary sinus conditions has increased. We tend to do a lot of OPGs and CT scan to evaluate radiologically the maxillary sinus diseases. You can do a diagnostic endoscopy. Now, endoscopy in the way of nasal endoscopy, we can take an endoscope and we can enter into the nasal cavity. We can check for the nasal cavity as well and at the sinus opening as well. Further functional endoscopy, if we do, we can go into the sinus and look inside the sinus as well. So endoscopy does help in diagnosing various sinus conditions as well. We can take a biopsy and a swab for culture and sensitivity as well. For malignant, benign conditions, infections, we can take biopsy of the tissue involved, and we can do histopatho as well as a culture sensitivity to get to a definitive diagnosis. So this is how we approach maxillary sinus diseases. Now, the most common cause for any condition affecting the maxillary sinus is sinusitis. Now, sinusitis, what do we understand from the word sinusitis? Sinusitis means itis in the word sinus is inflammation of the sinus lining. So you'll have all the cardinal signs of inflammation. This sinusitis you can classify as acute, subacute, recurrent, and chronic according to duration. Acute are mostly classified according to 4 weeks of duration. Subacute you have ranging from 4 to 12 weeks. Recurrent is more than 4 episodes in a year. And chronic is when the condition continues for 12 weeks or longer, you can classify them as chronic sinusitis. Now, the word sinusitis, it is very vague because if we look into the clinical condition, it is always the nose, the nasal mucosa is always involved apart from sinus. So it is more likely and more better to use the word rhinosinusitis because of the involvement of the nasal mucosa as well as the sinus lining are inflamed. So it is more better to use the word rhinosinusitis, acute rhinosinusitis, chronic rhinosinusitis. Right. Now, what is acute rhinosinusitis? If we try to understand what is rhinosinusitis is, nothing but what we normally have frequently. It is a common cold, that would cause rhinosinusitis, acute phase. Most common etiology for a starting of a acute phase of rhinosinusitis is nothing but a viral etiology. Most common virus is rhinovirus. Now, this causes inflammation of the nasal mucosa, of the sinus lining. They tend to produce a lot of secretions, mucus secretions. You tend to have pain in the sinus region, tenderness, because of the increased secretions, the inflammation of the sinus lining, the pain, swelling over this region. And typical of a sinusitis is when you bend down, there is increase in the pain over the maxillary region. The patient may complain of headaches. Patient would have otitis media, that is inflammation of the ear as well, referred pain to the ear because of the mucus secretions, the blockage of the approximation anatomical structure like the escutcheon tube opening, which is posterior to the floor of the mouth, floor of the nose, sorry. So this approximation will give you a range of signs and symptoms. Now, initially, always a sinusitis starts with viral, and those are self-limiting. Normally, it tends to heal in 7 to 10 days. To give them relief, we can always use steam inhalations, drainage of the ostium, drainage from the ostium. The mucosa should be patent so that the secretions which are produced inside the sinuses tends to come out. But what happens sometimes is the ostium tends to get blocked by the mucosal inflammation. The ostium of the sinus is around 2 to 3 millimeter. It is high up into the opens into the lateral wall of the nose, and the cilia. The cilia helps in pushing up the secretions from against the gravitation from this ostium high above, and that drains into the lateral wall of the nose. So one, the ostium, the second, the cilia and its movement. Third is ventilation of the sinus. These three things are very important for the physiology of a sinus to remain in health. If any three of this gets disrupted, it would land up into acute phase going into recurrent phases or chronic phases of sinusitis. Right. So what is the importance of a patent sinus? If there is a patent sinus, you have secretions which are produced getting thrown out of the ostium into the lateral wall of the nose. If the mucosal thickening takes place, the inflammation of the ostium takes place, and the blockage takes place, the ostium is not patent enough, what happens? The secretions tends to stay inside the sinus. It tends to increase in quantity and stagnation of the mucosa into the sinus. This creates a hypoxic environment as well because of the ostium which is clogged, does not allow ventilation. So it creates a hypoxic environment inside the sinus. So this creates an environment for bacteria to proliferate, right? The cilia tends to decrease their movements. The beat per minute tends to decrease in such environments. So the clearance of mucosa decreases over a period of time and becomes stagnant. And hence, the mucosa starts reacting to it by hyperplasia of the sinus linings. And that goes into chronicity. So acute always starts with viral, gets superseded by bacterial infection in the acute phase as well. The most common bacteria we find is Haemophilus pneumoniae, Streptococcus influenzus, and Myzorillus are the common bacteria which are found in the acute inflammatory phases. When such environment changes into anaerobic, you see anaerobic bacteria, Staphylococcus, which starts invading into this environment. So the clinical signs and symptoms are of those which are very typical of common cold. Now, if we do not treat any acute sinusitis, it can lead to orbital cellulitis through a venous drainage which is passing through the veins which has valveless. It can go up to the brain, it can go to the orbit through a venous channel, thrombophlebitis, and can give you orbital complications. It can give you cranial complications leading to loss of vision. It can give you a cavernous sinus thrombosis. So it's very important to treat sinusitis in the acute phase with medication. The initial way of treating a sinusitis is how we approach common cold. You do steam inhalations, you use decongestants like xylomethazolin sprays, which would, what would it do? It would cause vasoconstriction